put it to you all that even if you are bathing in a flowing river, it is wrong to waste water. The gaps that we've been talking about can be understood in a different way depending on where one is. Now, today, World Mental Health Day, and the WHO indeed has a mental health gap action program. But that's talking about the gap between need and available resources, looking at low to middle income countries and looking at where the burden of disease vastly overwhelms the resources reasonably able to be marshaled against those. Now in Cambridge or Cape Town or Prague, Brisbane or Yale, we're not, regardless of what you hear in the press about austerity, we're not in lands of want. But even here, we don't have the services that patients need. And in some respect, it's because these unmet needs fall between services, either because of design which doesn't encompass the full need, or simply because of poor coordination. And of course, that leads to a gap between expectation and reality. Now, you've heard many people speak today. Hope you can be able to keep even a fraction of all that we've heard today. And so, trying to reiterate some of the things that previous speakers have said. We heard from Emma, one of the things she said is that GPs are going to look at the physical health of patients with chronic psychosis, because she said she knows we don't deal with that very well. And when she says we, really, I'm sure she means all of us. We know that patients with chronic psychosis have a life expectancy 18 years less than somebody who doesn't. And 3/5 of that reduction has got nothing to do with suicide, has got nothing to do with direct mental health related issues, but has to do with poor physical health, cardiovascular health, diabetes, and so forth. So what can we do to bridge this gap? Now, the title of my talk is supposed to be the role of the emergency department, and I'm one of the consultants at Addenbrooke's in charge of the emergency department for mental health. And while I know that the emergency department has a role, a key role, in helping with this, the problem doesn't start there. Regardless of that, despite what Aidan said about our CQC report, which is good news because it hasn't been released next week, some of you will know that Addenbrooke's CQC report was released a little while ago. Now, one of the things that was mentioned in that, from a mental health point of view, was that Addenbrooke's was criticized to some degree for mental health in the community, which is interesting because that's CPFT's job, one would think. But again, we're saying that it's everybody's job. But Addenbrooke certainly runs the emergency department. We've heard today from GPs, we've heard and we will continue to hear from people in locality teams, social services, including mental health professionals who do mental health assessments, crisis team, inpatient care, police, NGOs, and so forth. But the point about the gaps between services is that sometimes poor coordination during the day or skeletal individual service provision, so you'll have one person in the home treatment and crisis team, you'll have a single liaison psychiatry nurse in the emergency department, you'll have a duty nursing officer in the inpatient unit, you'll have a junior doctor, you'll have somebody in the emergency duty team as a social worker. And not everyone's necessarily working all together. So the total out of hours provision is reasonable, but it's not certainly as joined up as it could be. What happens? People come to the emergency department. Now, the whole premise of promise, as it were, is to prevent unnecessary coercion and certainly to prevent big burly security guards jumping on people. So you'll be a little disappointed to hear that one of the most popular talks that I give at Addenbrooke's is the management of an agitated patient. And the point that I try and put across in that talk is that management of an agitated patient is not entirely intramuscular haloperidol and lorazepam. That message doesn't always go through. So the role of the emergency department in helping close the gap is not simply to try to treat the patients well when they arrive in the emergency department, but hopefully to work well with everyone outside the hospital to prevent people coming to the emergency department in the first place. Local efforts, to end off, have been to resurrect something which worked well before. The FACE team was looking at frequent attenders. It was shut down because people said it wasn't useful. It was a great service which was based in the emergency department, would actually go into people's homes, look at the complex frequent attenders, find out what the nub of the problem was in that individual case, and try and deal with the problem, whether it was housing, drug-related, or other. We've lost that, but we've realized we need it back. And the other thing that we're doing locally, you will have heard of the 5-year forward review, some of you come out of the NHS. Now, Vanguard sites were chosen. There were 8 with regard to emergency care. Some were chosen because they were centers of excellence and could be flagships and show better practice. Others were chosen because they were struggling and desperately needed help. We won't dwell on why Cambridge was chosen. But certainly Cambridge has been chosen as a Vanguard site, and we are hoping to implement much of this here today by having a control center for referrals. So we have a 24/7 point of contact for crisis and assessments, having clear channels of communication between all services, and of course not having left alone a postcode lottery, but an age lottery, and treating somebody at the age of 16 as well as we would treat them at the age of 18. Thank you very much.